Hi everyone. I just want to, record a short version of the intro to PKPD. Okay, and you will use this short version to, prepare tomorrow's pre-assessment quiz. Here is the learning objectives of the, how to use the drugs in various disease states. You should be able to, explain how to use that after this module, after this lecture, and you should be able to define pharmacokinetics and discuss its applications in this module. And also, you should be able to define biopharmaceutics and discuss its application after this module. And actually, if you have learned, after we learn this module, you will know there are overlaps and the relation between pharmacokinetics and biopharmaceutics, okay? And you should be able to define bioavailability and parameters used to assess bioavailability. You should be able to, list the factors that influence bioavailability. Actually, the factors cover many different fields, okay? And you should be able to explain some other important definitions. And you should be able to, identify or distinguish intravascular and extravascular routes of drug administration. You should, be able to explain the plasma concentration versus time, plot. And, following the administration, following the intravascular and extravascular administration. After this module, you should be able to explain what ADME is, definition for A, for D, for M, and for E, and also their implications on therapeutic outcomes you should be able to explain. And also, you should be able to explain the importance of absorption and the elimination process in bioavailability, and the parameters used to assess the rate of absorption and the extent of absorption. You should be able to use the parameters to assess that, okay? And like Tmax, Cpmax, like AUC, area under the curve, 0 to infinity. And also, you should be able to list the factors that influence absorption rate constant, that is Ka, and elimination rate constant, that is K. Actually, here, the flow chart here shows the role of pharmacokinetics in drug disease management. Let's look at the flow chart. From the top, okay, start from the top, a diagnosis is made by a healthcare provider. Then a drug is selected, okay, according to that diagnosis. Then you need a dosage schedule, okay? Dosage schedule is designed to reach a target plasma concentration. That's a must. And according to that, the drug is administered to the patient. Then after that, two things must be done. First is the patient assessment. The patient assessments are performed. Then the drug concentrations. The second thing, drug concentrations are determined. Then, after you get the two information, a pharmacokinetic model is applied and a clinical judgment is used. If you look at this arrow, if dosage adjustment is necessary, then the dosage schedule is adjusted. Then the next several steps will be redone, okay? And that actually this chart perfectly shows the role of PK, pharmacokinetics, in drug disease management. Is the skeleton. Of course, you need to do more than that, maybe, but that is the basic steps and flow, of the role of PK in drug disease management. pay attention to this two important notice here, okay? The formulation of a dosage form of a drug must be accomplished in a manner that will deliver a recommended dose to the site of action or a target tissue. The dosage form can be many, various, okay? That the dosage forms used in pharmacy. And also, when the drug is delivered to the site of action or target tissue, we must consider the principles of physical pharmacy and pharmaceutics will be applied. And another important notice I want to let you know is a dosage regimen must be established to provide an effective concentration of a drug in the body as determined by the physiological and pathological needs. Okay, actually, for those purposes, for those needs, pharmacokinetics and biopharmaceutics must be, the principles in there, or application of those two, must be there. The drug with a high therapeutic index is not always for good use, have a good use, okay? Actually, if that drug undergoes rapid decomposition in the GI tract, then maybe little use if this drug is taken orally. And another possible, just give you some example. Another possible reason is, if this drug fails to reach the general circulation, or called systemic circulation, due to dissolution or other formulation-related problems or related issues, actually, also this drug cannot be used, or of very little use. And also, besides the drug, therapeutic or dissolution or decomposition reason, actually, if the drug is too irritating to be administered parenterally, then it might be also little use. So why, we give you so many examples? And, I just want to show the final goal in the drug development process is to develop an optimal dosage form to achieve the desired therapeutic goals and outcomes. Okay, that's our goal. Here we summarize why we need to optimize a dosage form. Actually, the reason is we try to develop a dosage form that can provide the maximum therapeutic effect with the least of drug to achieve the best results consistently. That means not just once or twice, consistently. And why the least amount of drug? Because we don't want unnecessary side effects, okay? And also, cost-wise, also we want the least amount, right? And in other words, if I explain another way, there are several factors play an important role in determining the activity of a drug administered through a dosage forms. And actually, if we want to give a definition for pharmacokinetics, this sentence is from a very famous paper published more than 40 years ago. Actually, more than 50 years ago. And it is a very famous paper, okay? Published in Journal of Pharmacokinetics and Biopharmaceutics. And pharmacokinetics is the study of kinetics. That's the reason why it is called pharmacokinetics, right? It is a study of kinetics of absorption, distribution, metabolism, and excretion. ADME. A means absorption, D means distribution, M means metabolism, and E means excretion of drug, and their corresponding pharmacologic, therapeutic, or toxic responses in man and animals. And If you look at the applications of pharmacokinetic studies, actually, the studies are used for bioavailability measurements and also can be used to analyze the effects of physiological and pathological conditions on drug DNA, right? Disposition or distribution and absorption. And also we need to know the pharmacokinetic profile of a drug to adjust the dosage in disease states. Even same disease, when the level is different, the dosage used is different, okay? And we can use we can apply the pharmacokinetic studies to investigate the correlation of pharmacological responses with administered dose. And also, we can use this PK study to evaluate drug interactions. You will learn more about drug interaction later in P2. And also, we can do some clinical predictions by applying the PK studies. For example, we can use pharmacokinetic parameters of a drug to, individualize the drug regimen, because everyone is different. Even same disease, every patient is different, okay? And when we do the clinical trial, we do that for a population. But for a specific individual, we can use the PK parameters of the drug in that individual to individualize the drug regimen, and then we can provide the most effective drug therapy. And in each case, that means in each case, the use must be preceded by observations. And we introduced, or we gave, definition for the pharmacokinetics, right? And what is the best, or not the best, what is the definition of the biopharmaceutics? Okay, it is the study of the factors influencing the bioavailability of a drug in man and animals, and the use of this information to optimize pharmacological and therapeutic activity of drug products. And we talk about factors, right? Then the examples of some factors are listed here. For example, like the chemical nature of a drug. Of course, determined by the chemical structure of a drug. For example, is the drug a weak acid or weak base? It is a large or small molecule drug? Or, how about is a lipophilicity? All of this. And another very important factor is inert excipients used in the formulation of dosage form can affect also. Like, for tablets, what is the binding agent used? And for emulsions, what is the surface active agent used? For, diluent, what is the diluent used? When we try to, dilute the powders used for capsule granules. And what is the lubricant used in capsule, or granule or tablet formulation? All of this. And actually, besides that, the factor also include the method of manufacture. For example, like dry granulation, like wet granulation, like direct compression, etc. Okay, and also, of course, the physical chemical properties of the drugs, like particle size distribution, specific surface, as I just mentioned, like lipophilicity, polymorphism also, and we introduced what polymorphism is, and also amorphous or crystalline, hydrous and anhydrous form, all of this. So let's summarize. The goal of biopharmaceutical studies is to develop a dosage form that will provide consistent bioavailability at a desirable rate. Okay, and the I believe bioavailability is not the first time you heard in this course. Even in pharmaceutics one, I believe Dr. J has mentioned quite a bit, even other faculty has mentioned quite a bit, right? So the importance of a consistent bioavailability can be very well appreciated if a drug has a narrow therapeutic range. Okay? Why? Because if you look, we have a figure later, okay? If you look at the plot, you will see, okay? Actually, the example given here is nanoxin, okay? And actually, we have a table on that, and you will see why and how narrow, not just why, how narrow the therapeutic range for this drug, for nanoxin. Okay, that means because the range is so small, that means a small variation in blood levels may result in toxic or subtherapeutic levels. Therefore, it is accurate to make a statement, okay? Though the goals of pharmacokinetics and biopharmaceutical studies are different, these two disciplines are intertwined and inseparable. They are close enough for us not be able to divide them to two different disciplines. Okay? They are kind of, overlapped. Not just overlapped, but relates to each other a lot. Let's review and go deeper about the bioavailability. What is bioavailability? And how do we assess bioavailability? Actually, if you look at the guideline for biopharmaceutical studies in men, published in 1972, that is already a very established, scientific field. Bioavailability is the relative amount of an relative, right? It's not the amount, it's the relative amount of an administered dose that reaches the general circulation and the rate at which this occurs. The rate and extent to which the active ingredient or therapeutic moiety is absorbed from a product and becomes available at the site of drug action. Okay, so that is the definition of bioavailability, okay, both from the APHA and FDA. Then, if we look at, we want to discuss, we want to, assess the bioavailability, then which parameter? For example, if we want to assess a student's performance, because I'm a professor, so we will use like exam grade, or like lab grade, or presentation, the evaluation for the presentation. Then which parameter permit the assessment of bioavailability? Actually, as we introduced, okay, the bioavailability is the relative amount, okay, of an administered dose that reaches the general circulation. That means the extent. And it can be, bioavailability can be assessed from the knowledge of area under the plasma concentration versus time curve. We call it AUC. Area under the, curve, AUC. C, A means area, U means under, C means curve. And besides that, and also the rate at which this occurs. And the rate of absorption can be assessed from two parameters. One is called Tmax. That if you look, we will have a plot later. If you look at the plot, the curve has a peak, so that is peak time. And also the concentration at the peak time, the plasma concentration at the peak time. we call it peak plasma concentration, Cp max. So two parameters can be used to assess the rate of absorption. Okay, and now let's look at the plot. We mentioned the plot before, This plot is a typical plasma concentration versus time plot. Actually, this curve, if you see the dots here, right? Dots here, dots here, dots here. Actually, this curve is produced by the administration of a drug via extravascular route. Okay, you will learn different routes later. Okay, and you will see the two horizontal lines here. One is called MTC, another is called MEC. And the concentration between the two is the therapeutic range. That means when the plasma drug concentration is in that range, we want that. That is the toxicity is below tolerance and the drug has a therapeutic effect. Okay, therapeutic range. And if you look at the curve, okay, the lower horizontal line, the cross section between the curve and the lower, all called MEC line, actually the time to that point, if you can see my mouse pointer, that is the called onset of action. And another cross section also on the MEC line, between the MEC line and the curve. Okay, actually that is a termination of action. Why we call the 2 points onset and termination? Because after the termination of action, the plasma concentration is lower than MEC. So no, we don't have the drug don't at that moment the plasma drug concentration is not in the therapeutic range. Okay, and if before the point onset of action, actually, you will see actually, also no acceptable therapeutic effect, right? The concentration is lower than the MEC. So between, we call it, duration of action, okay? And before that, we call it, absorption rate, absorption phase, because you need absorption, right? And after that, we call it, elimination phase. And that is basically all the information you need from this plot. This slide shows you the definition of onset or explanation what the onset of action is, what is the duration of action is, what is the termination of action is, and also the therapeutic range. I have explained already in the previous slide. Okay. Actually, this table shows you the therapeutic range for certain commonly used drugs. And, lanoxin, the second one. We mentioned that before, right? Lanoxin, actually, that is used for congestive heart failure, CHF. If you look at the therapeutic range of lanoxin, it is 1 to 2 microgram per liter, or if we convert to nanogram per milliliter, still 1 to 2. Okay, actually, if we think about 1 liter, is a big volume, but the concentration is 1 to 2 therapeutic range. It's 1 to 2 microgram. Microgram is a very small amount. That means the therapeutic range for lanoxin is very small. And even small, change of the plasma concentration of this drug actually can go out of the therapeutic range. So that's the reason why I mentioned, lanoxin before. Okay, and you are not required to memorize, the range, the number, and the therapeutic use of those drugs. This table is for your, reference. But nanoxin is a special example. You must know. Okay, their therapeutic range is very, very small, and why we should pay extra attention to that. The drug administration route can be classified into two major categories. One is intravascular, another is extravascular. For intravascular, we have subtypes too. The first important type is intravenous, and including bolus and infusion, and we also have intra-arterial, okay, administration. Actually, there are some special things for all important features of IV administration. Okay, because this drug directly go to the direct go IV, right, intravascularly. So there's no absorption phase. So you should pay attention to the absence of absorption phase. And also because of that, the onset of action is immediate. And also, entire administered dose is available to produce the pharmacological effect because directly go to the blood, right? And also this route, some important note. This route is used more often in life-threatening situation. And if there's some adverse reactions, because immediate onset of action. So if there are some adverse reactions, it's hard, it's very difficult, sometimes impossible to reverse or control. And also because of that, accuracy in calculations and administration of drug dose is very critical. This plot shows you the administration of a drug by intravenous solution. Okay, and if you look at here, you can see the lines for MTC and MEC. That is in between is the therapeutic range, right? And this plot is on IL plot, and site of administration and measurement is the same for drug B and A. But if you look at there, no, both drug B and the drug A curves, they don't have the absorption phase, right? Phase of absorption. But because both of them have the same MEC, so their onset of action is slightly different. Okay, slightly different. This slide shows you the extravascular routes of administration. Actually, we have introduced in Pharmaceutics 1. For extravascular admin, there are some important features. They have absorption phase, okay, the steep, inclined to the up. And actually, the onset of action is determined by factors such as the formulation and type of dosage forms, route of admin, physical chemical properties of drugs, and other, a lot of other physiological variables. The entire administered dose of a drug may not always reach the general circulation. That means for extravascular administration, it is possible the absorption is incomplete, not complete, incomplete. This figure is a typical plot in RL paper of plasma concentration versus time. Actually, following an extravascular vascular administration, of the same drug, same dose. But for A, B, and C, the formulation is different. So you can see the peak time, the CP max are different for all the three. And therefore, the onset of action and termination of action is different. Even the elimination phase is different. The absorption phase is different. The curves are different. So same dose, same drug, just the formulation is different. We have introduced or explained absorption in many lectures already. Here, let's review. Absorption is defined here as a process by which a drug proceeds from the site of administration to the site of measurement. Okay, usually blood plasma and serum. Very occasionally, maybe the specific disease site, but usually the blood, usually in the systemic circulation system. Okay, the measurement in there. And please note that the site of drug administration and the site of drug measurements are different. That's very important. Actually, the absorption phase will always, be there. It's not absent, okay? Always be present when a drug is administered via an extravascular route. The, passive diffusion is responsible for the transfer of a drug from the site of admin to the site of measurement. Let's look at the next two slides. The next two slides will review the process and maybe introduce some factors that play, important role. Let's look at this picture, okay, or this figure, okay. Now, if the drug is taken orally, and the drug molecules pass through the GI tract, then absorbed to the blood, right? And here F shows the very left. F shows fraction absorbed. Then, the enzymes on the gut wall will, decompose part of the drugs. Then, of course, in the GI tract, the drug will be metabolized, right? And then the drug, part of the drug will remain its original, structures or status to go to feces. Let's look at the drug absorbed to the blood. They will go through the portal vein, and then part of them will be metabolized by the enzymes in the liver. Then the rest will go to the site of measurement. We use F star. And the enzymes, the metabolisms by the enzymes in the liver, we call that first pass effect. Okay, first pass effect. Okay, that means the drugs are lost in the GI tract. Even the drugs absorbed to the portal vein will be lost. Some part of the drug will be, will be lost after first pass effect. Okay, only fraction of the drug will go to the site of measurement. This slide is also kind of introduce and also review for what we have learned before, okay? For example, like a tablet, for oral use, okay? Orally taken. Even like suspension, solutions of capsules, emulsions, okay? And the, GI tract, the pH of the lumen fluid, of course, affect the, will decompose or affect the stability of the drug, right? Then for the tablet, actually, or even the capsules, and also for dissolution for suspensions, for actual disintegration time and dissolution time effects, right? And also the surface area of the small intestine affect the absorption. And many things, okay? And we also need to consider the intestinal transit time. Okay, many things are involved in the drug absorption. Actually, some are from the physiology, some are from the formulation. Okay. We mentioned absorption rate constant, right? Absorption rate constant, the unit is, the reciprocal of hour to -1. And we use Ka. A means absorption, K means rate constant, okay? And actually, the administered dose will also, besides the absorption rate constant, even the administered dose will influence the rate of absorption. Okay? Actually, we learned that from Fick's first law of diffusion, right? If you still remember, we introduced Fick's first law of diffusion and second law of diffusion. Okay? Fick's laws of diffusion definitely affect that. And that is, K is constant, unit is hour to -1. Let's look at the absorption rate. That means the amount of drug absorbed per unit time. Okay, so the unit is milligram per hour. The absorption rate is directly proportional to the administered dose. That is linear. The relation is linear. Okay. Actually, absorption rate must decline with time. Also from the Fick's laws of diffusion. Okay. Mostly from first law. Okay. And Ka, absorption rate constant, is a constant for a defined condition. Okay, if the condition is exactly the same, fixed condition, actually Ka is a constant. But we cannot say, okay, change the drug, go to another patient. That is not. But for a defined condition, Ka is a constant. Another important feature for Ka is, even for the same drug, in the same subject, patient or animal, okay? Actually, Ka will be different if dosage form is different and the administration route is different. That is the first important, feature. Another important feature is Ka for the same drug and in the same subject will be different if the dosage form is same, but the formulation is different. For example, maybe different excipients, or even the methods of formulate, the procedures steps can be different. And this means the rate of absorption for an identical dose of a drug will be different if the route of adenine is different, dosage form is different, and the formulation is different. There are also some other important features for absorption rate constant. Ka depends on the drug dissolution and the pH at the site of administration. Okay, and so because of that, the drug dissolution process is very critical in the drug absorption. For example, like rapid drug dissolution can result in higher absorption rate constant. Okay, that is from dissolution. Drug dissolution can affect the Ka. And of course, the faster drug absorption. And if the drug dissolution is slow, actually, we mentioned this a little bit in our Pharmaceutics 1 lecture, right? Slower drug dissolution can yield lower value for the Ka. And of course, results in slower drug absorption. And the Tmax and the Cpmax Those two are used to assess the rate, of absorption, as I mentioned before. Distribution, the first ADME, right? The first is absorption. The D, the second letter, means distribution. Distribution is a process of reversible transfer of drug to and from the site of measurement, usually blood or plasma. This phase will always be present, okay? No matter extravascular or intravascular, no matter what the route of administration, okay? And actually, any drug that leaves the site of measurement and doesn't return has undergone elimination. Okay. And see, this is a chart to show you the drug distribution, kind of. Although in a beaker, but we just think that it's a human body, okay? And the colorful blocks are the various organs in the body. Arrows indicate the transfer of drug from blood to organ and from organ into blood. And if you look at the drug in the blood, okay, drug in the blood, and you will see, okay, the drug distribution process in the body following, the administration of drug. And then, of course, the drug from the blood to the organ, and also from organ to the blood. And when we talk about, drug absorption, actually we talk about the rate extent, right? And for the distribution, we also need to discuss the rate and the extent. The rate and extent of drug distribution is determined by how well the tissues and organs are perfused by the blood, like liver, well perfused. So the distribution is better, okay? And also depends on the binding of drug, okay, to plasma proteins and the tissue components. Every drug is different. Or they can be similar, but they are different, okay? And also depends on the permeability of tissue membranes to the drug molecules. If you still remember, in Pharmaceutics 1, we introduced permeability, okay? That relates to the partition coefficient and other factors. And the permeability of tissue members, okay? Tissue members, they are basically lipids, okay? With proteins, of course. Lipophilic, okay, to the drug molecules. Permeability. And all these factors are determined and influenced by the physical chemical properties and the chemical structures of a drug molecule. That's what we learned before, right? So see, everything you learned in Pharmaceutics 1, you will see again in the following, modules in Pharmaceutics course series. The apparent volume of distribution parameter. Okay, you will learn more about the apparent volume of distribution later. Okay, actually, this parameter permits the assessment of the extent of drug distribution. So for this lecture, for this module, you must know. Okay, so for certain assessment, what parameter must be used. Okay, and another important knowledge point is the more lipophilic the drug, the higher will be the value for the apparent volume of distribution, the relationship. And the greater will be the penetration of a drug into the body tissues. Because the body tissues, the membranes, they are kind of lipid-based thing, right? Okay, and of course, the extent of drug distribution, because more to the body, extent of the distribution, drug distribution is higher. Okay. Apparent volume of distribution is a property of a drug. That is a property of that certain drug. And it is constant for each drug. This sentence is very, very important. Its value is affected, due to disease state physiological abnormalities due to change in blood composition and change in the tissues and membrane permeability characteristics. That is, very important, message for apparent volume of distribution. Okay, and this parameter is used for the assessment of the extent of drug distribution. There are some, I cannot call it cut-off lines or cut-off values or threshold, but there are drugs with low apparent volume of distribution and drugs with high volume of distribution. For low apparent volume of distribution, about 9 liters, and actually cannot be less than about 5 liters because our blood is like that. Okay, and for drug with high volume of distribution, greater than 800 liters. 800 liters, and this parameter is independent of dose administered as well as independent of route of administration. I mean, the apparent volume of distribution. Okay, independent. This sentence is very, very important. Okay, and the package insert. If you have a box of drug, actually, the package of drug, there is one thing called a package insert. A lot of information printed on that, okay? The package insert of each product and many books will provide you the value for this parameter. You can search, even literatures, you can search in many places. This is the only drug property that determines the suitability of a compartment model to describe plasma concentration versus time data accurately. Okay, and this sentence is for information mostly because you will learn more about that later. You will learn, compartment model is more in, PK course, and very important. And actually, PK, pharmacokinetics, we mentioned pharmacokinetics is a discipline, right? And for investigation discipline or study discipline or scientific discipline, pharmacokinetics of drugs are often described by using compartmental models. For example, like one compartment, 2 compartments, okay, or 2 compartment model. If the drug distribution equilibrium is attained rapidly, because like we, put a gas in a room, okay? If only one compartment, should be very fast, right? Then, if that is the case, one compartment model can describe the concentration versus time date accurately. Because we need rapid, right? If not rapid, not one compartment model. Okay, regardless the route of drug administration. Don't need to consider that. Another case, if the drug distribution equilibrium is attained slowly or very slowly, 2 or 3 compartment model will be necessary to describe the concentration versus time, accurately. So that is slowly or very slowly, okay, to be achieved. The distribution equilibrium, the balance, is attained slowly or very slowly. 2 or 3 compartment model will be necessary. That means not like put a gas in a room, that the whole room is filled, right? That is one compartment. But if slowly, 2 or 3 compartment model will be necessary. When you try to develop or apply PK models, okay, actually equations are required to use to describe the concentration versus time or date accurately. You need equations, very accurate equation you have to use. And the equation required to use is determined solely, okay, by the compartment model chosen and the route of drug administration. Nothing else, solely by the two. For example, If a drug is administered intravenously, you use the equation below. Cp equals to Cp0 e to negative Kt. K is the the rate constant. Okay, rate constant. And if the right equation to describe concentration versus time data accurately, or only for one compartment model, okay, you use the below, the equation below. That is for one compartment model. Okay, intravenous, one compartment model. If the right equation to describe for a two compartment model, you use different equation. For drugs administered extravascularly, there will be different sets of equations to describe plasma concentration versus time data. And actually, you are not required to know which equation to use. The key point on this slide is the equation required to describe concentration versus time data accurately is determined solely by the compartment model chosen and the route of drug administration. That's the key point. Then let's go to the M in ADME. M here means metabolism, as we introduced before. What is metabolism? Metabolism is a process of conversion of one chemical species to another. Okay, and for example, like aspirin, commonly used drug, right? And aspirin, go to salicylic acid. That is active, metabolite. So that's a drug basically. Okay, take a pharmacological effect, and then metabolites eliminated by the body finally. Okay. And actually, besides salicylic acid, aspirin can be converted to salicyl glucuronide, salicylluric acid, or gentisic acid. All of them are inactive metabolites. So only salicylic acid, have therapeutic role, right? And all the metabolites are eliminated. That's give you one example about metabolism. More than that, actually. Here is a chart. Okay, so the metabolism happens, and then the structures are changed. Okay, for aspirin. This slide gives you some examples of therapeutically active metabolites. You are not responsible for the examples, for the quizzes and exams. And this slide gives you additional examples of active metabolites, also for your reference only, not for quizzes or exams. After examples, actually I want to let you know metabolism may not always be present, since not all the drugs undergo metabolism. Not all. Actually, from previous slides, you have known, right? Metabolites do possess different chemical structures compared to the mother, molecule, right? So, because of that, physical chemical properties of metabolites might be or will be different. Okay, definitely some difference, but some can be very different. Though formulation of metabolites occurs in liver, most metabolites are removed from the blood by the kidneys. That's another important note you should know, knowledge point. Okay? Actually, metabolite kinetics is a separate topic of discussion. Actually, when I was in my PhD program, that's a different course. or even different major, okay, even different major. E, let's go to the E in ADME. Elimination is the irreversible loss of drug from the site of measurement. Okay. Excretion, it is a reversible loss of the drug in a chemically, unchanged form. Elimination of drugs occur by two processes: metabolism, as we just mentioned, and excretion. Okay, not just the excretion, even metabolism is one. For some drugs, even major process of loss. And this phase, E, elimination, will always be present, no matter the route of drug administration. Always be there, because drug always need to be metabolized and removed from the body. Okay, always be there. And there are two organs majorly responsible for drug elimination. One is kidney, another is liver. Okay, kidney is a primary site for removal of drug in a chemically unaltered, unchanged form, okay, as well as the metabolites of that drug. Liver is the primary organ where the metabolism happens if the drug can be metabolized. Not always all the drugs have that phase, as I mentioned before, right? And the lung occasionally may be an important route of elimination for substances of a high vapor pressure can go through the gas, lung. But the main organs are liver and kidney. Kidney usually, kidney is a primary site for removal of unchanged form, and liver is the metabolism. Is for metabolism purpose. And elimination of a drug is characterized by three parameters. Okay, see, we always talk about parameters, right? Three parameters: elimination rate, elimination half-life, and elimination rate constant. Okay, and the unit you must know, not just the three parameters, the unit for elimination rate, similar as the absorption rate, same as, right, milligram per hour. And for the half-life, of course, the unit for time, right, and the elimination rate constant, the reciprocal of the time. And the elimination half-life and the elimination rate constant are related with each other by the following equation, half-life equal to 0.693 divided by K. Okay, actually you will learn chemical kinetics, same as that one. Okay, exactly same, but only applied in the drug elimination. Okay, actually that means why we want to introduce this. That means one can determine the elimination rate constant from knowledge of the elimination half-life simply by rearranging the equation. For example, if you know the K, you can calculate the half-life, right? T half-life. And if you know the half-life, you can calculate the K. You only need to use the number 0.693. That number you must memorize. And actually, we need to talk about the package insert again, okay? And the elimination half-life for each drug is available through package insert, and also from you can search from the database, okay? And many other books. And elimination half-life is constant for each drug. It is independent of dose administered as well as route of administration. That is a very important statement for you again. Okay, and there are drugs with a short elimination half-life, and also drug with long half-life, elimination half-life. Short is about 1 to 4 hours. And here give you the example for 2 examples for the short half-life drug. Okay, 2 hour, about 2 hour, and you are not responsible to memorize that, but you should know. Okay, short elimination half-life is about 1 to 4 hours. We also have, drugs with longer half-life, elimination half-life. And here give you same as the short one. Longer one, the examples you don't need to memorize. But I want to let you know long can be very long, actually. Like phenobarbital, 110 hours. Okay, and there are also examples even longer than 110 hours, longer than about 5 days. Elimination half-life of drug is affected in a renally impaired condition. Okay, kidney has a problem. Because the kidney, eliminate the drug. Okay, play a major role. So elimination half-life become longer in a subject with renal impairment. Does not function. The kidney does not function well. Okay, that you must know. Okay, and also drug elimination is adversely affected as a result of kidney failure and or other disease states. Okay, and kidney function can also be assessed by a parameter called creatinine clearance. Creatinine clearance. If kidneys function, ineffectively, it will result in lower creatinine clearance value. Okay, and it is reflected in longer. It's adversely, right? Adversely, longer half-life, elimination half-life, and lower rate constant, and lower rate, right? And another, potential route of drug removal is moms, breastfeeding moms, milk. Actually, although it's not a significant route for elimination for drug for that mom, but it may be consumed by the infant. Infant is small size, and even small quantity can affect the infant. Right? Can be a sufficient quantity to affect the infant. Disposition. Okay, why we want to use the word disposition? Because once the drug is absorbed, the drug is distributed simultaneously to all tissues, including an organ responsible for elimination. Okay, because distribution does not distinguish which organ I want to distribute, right? So even including an organ responsible for elimination. So because of that, the distinction between the elimination and distribution is often very difficult. Okay, actually here Dr. J cited a sentence here. When such a distinction is either not desired or is difficult to obtain, disposition is the term used. Okay, disposition. Most time it's hard. Okay, it's hard. And let's look at the long sentence here. Okay, explained better. Disposition is defined as all the processes that occur subsequent to the absorption of the drug. Hence, by definition, the components of disposition phase are distribution and elimination, because you cannot distinct the two phases, the two processes, right? So then the phase is called disposition. Okay, disposition phase. If you still remember, when we talk about bioavailability, actually we said peak time, peak plasma concentration, AUC, are used to assess bioavailability of a drug. Actually, for bioavailability, if we specifically point bioavailability, that is AUC. But if we talk about the rate, how fast of the bioavailability, peak time, and peak plasma concentration, so we don't distinct all the three sometimes. And actually, bioavailability is the one of criteria to assess therapeutic outcome. Let's see the parameters one by one. Let's look at this, SL plot. Plasma versus plasma drug concentration versus time, plot. Actually, we have introduced, right? So where is the onset of action? Where is the termination of action? Where is the absorption phase? Where is the elimination phase? Where is the therapeutic range? Okay, and if you look at the peak, that is the peak. The time is the peak time, and the concentration is the peak plasma concentration. And the areas under this curve, okay, that is AUC. So that is AUC, area under curve from 0 to infinity. Okay, so and that is is a typical plasma concentration versus time plot. Okay, that is also, as I mentioned before, that is an extravascular route. The drug is administered via an extravascular route. And the peak time. Peak time, let's look at the peak time. Okay, T max, usually we use hours, okay, as the unit. It is at which body displays highest or maximum plasma concentration, because that is a peak, right? And this parameter, peak time, reflects the onset of action, where, a drug is administered extravascularly in that plot. Reflects, but not the peak, okay? Can have some relation to that, okay? The faster, actually why onset of action? Because it can show how fast the drug absorbed, okay? The faster the drug absorption, the shorter is the peak time, and the quicker is the onset of action. Actually, peak time can be influenced by the route of drug administration, the dosage form, and the formulation of a dosage form. And peak time can also be influenced by the renal impairment, okay, the dysfunction. It will be longer in a renally impaired subject because elimination is harder, of course. The onset, of action will be slower. And this parameter Tmax can be calculated as the below. Okay. And you don't need to know the formula now, but I just let you know. You will use that later. Okay, it's more like build up your knowledge one step by another step. And besides the peak time, we also have another parameter. We need to consider the peak. Peak plasma concentration, CP max. Okay, and that is the highest plasma concentration when time is equal to peak time. Okay, in the whole curve, the plasma concentration is highest at that point, and also the time relates to is, peak time. And this parameter reflects the intensity of the response. The higher the value within the therapeutic range, the better is the response. Actually, it is why we talk about the peak plasma concentration, because that is highest, right? It is preferred and ideal if the peak plasma concentration is within the therapeutic range. Because of that, because only like that way we can obtain the optimum therapeutic outcomes. And actually, the peak plasma concentration is influenced by the route of drug administration, the dosage form, and the formulation of a dosage form. In a renal impaired condition, peak plasma concentration will be higher because less or slower, the drug can be eliminated or excreted. Okay. Cpmax can be calculated as the equation on this slide. Okay, you are not required to know that now, but it's more like for your information, make you be familiar with the whole set of parameters. I here is the intercept of plasma concentration, time plot. And of course, Tmax here is the peak time, and K and K are the absorption and elimination rate constants. Okay, and the units for rate constant is hour, the reciprocal of hour to -1. And actually, this parameter, the Cpmax, is directly proportional to the administered dose. Cpmax is directly proportional to the administered dose. On this slide, this knowledge point is very critical for you to know. You will be tested on that. Okay. Area under the plasma concentration versus time curve. Okay, that is AUC. AUC reflects the amount of administered dose that reaches the general circulation. Integrated, if you look at the AUC, is the area under the curve. If you still remember the integration calculus, right? In integration in calculus course, actually, it is the total amount. Reflects the amount of the drug that reaches the general circulation totally. Actually, the amount of the dose that reaches the general circulation, we use F times dose. F is a fraction of that. Depend on the fraction absorbed, big F, and the fraction of the absorbed dose that survives, F star, the metabolism. Okay, if cannot survive, what's the point? Because they cannot even reach the general circulation, although they can be absorbed, right? So depends on two, the fraction absorbed and the fraction that survives the metabolism. Okay, this one actually I have shown you before, right? This picture, this slide, and part, fraction F, big F, fraction absorbed, F star, fraction can survive through the first pass effect. And AUC for orally administered dose, okay, administered drug, can be determined by the following, equations, like F, times dose divided by KV. K is the elimination rate constant, and V is apparent volume of distribution. And this parameter is influenced by the route of drug administration, the dosage form, and the formulation of a dosage form. Many things, okay? And this parameter is directly proportional to the administered dose. Okay, as I think this part I mentioned before. So there's one summary. Summary is always important. Okay, of introduction to pharmaceutics and and pharmacokinetics and also ADME process. Okay, and we introduced biopharmaceutics and pharmacokinetics. We discussed the goals of kinetics and biopharmaceutics study, and you should be able to define bioavailability and discuss parameters used to assess bioavailability. And also, you should be able to compare the plasma concentration versus time profile for drug drugs administered intro and extravascularly, different shape of the curves, right? So, and is there any like absorption phase? And how about what happened to the curve? So you must know. And is the whole, medication or drug can be absorbed? The difference. And also, we introduced quite a bit about the difference between intro and extravascular routes of administration. And also we introduced the A, D, M, E, one by one. What is A, what is D, what is M, what is E? What does that mean? And what's the implication, okay, of this on the, therapeutic outcomes. And we also mentioned the parameters for assessment for like bioavailability, like absorption. What kind of parameters you use to assess?